Hello there. There are women who think something is wrong with them. They dread intimacy, become tense up even before it happens. They feel pain and carry this pain, yet never say it out loud to anyone due to the shame of what would people say. If that's you, I want you to sit with me for a few minutes during this video because pain during intercourse is not something you are meant to endure or normalize, and it's not just in your head. Dyspareunia Vaginismus are two of the most common cases of genital pain women complain about. They are often confused and sometimes they actually overlap each other, but require different approaches to treatment. Understanding these differences is the first step towards relief, healing, and reclaiming your confidence. Dyspareunia refers to the persistent or recurrent genital pain associated with sexual intercourse. It can be at the vaginal opening, which is termed superficial dyspareunia, or deep pelvic pain with thrusting. For some women, the pain lingers even after intercourse has ended, and it could be structurally, hormonally, neurologically, or psychologically. Note that dyspareunia is a symptom, not a disease, okay? Superficially, dyspareunia feels like burning, stinging, tearing, or rawness of the entrance of the vagina, while deep dyspareunia feels more like aching, cramping, or a sharp pelvic pain. Common triggers of dyspareunia includes infections such as recurrent vulvovaginal candidiasis, bacterial vaginosis, trichomoniasis, or untreated STIs like chlamydia and gonorrhea. These can inflame the vaginal mucosa, and these inflamed tissues become hypersensitive. So when penetration occurs, pain receptors or the nociceptors are already activated and pain perception is amplified, hence the occurrence of dyspareunia. Hormonal factors are also triggers of dyspareunia. Low estrogen levels during postpartum, breastfeeding, perimenopause, menopause, or the use of certain hormonal contraceptives can cause vaginal atrophy, which is where the vaginal tissues become thinner and they become less elastic and poorly lubricated. This leads to friction, painful intimacy, and initiate dyspareunia, which may later lead to anticipatory muscle guarding or even vaginismus. Structural conditions like endometriosis is a classic cause of dyspareunia, especially when lesions involve the uterosacral ligaments. Adenomyosis, fibroids, ovarian cysts, or even pelvic adhesions can cause deep pelvic pain during intercourse. Structurally also, scar tissues matters because women who have had episiotomies, perineal tears, and pelvic surgeries could develop tight or hypersensitive scar tissues. Sometimes dyspareunia is functional because inadequate arousal would lead to poor lubrication. Without sufficient arousal and relaxation, the vagina doesn't fully elongate and lubricate, causing painful intercourse in the process. Now, who are susceptible? Women with low estrogen levels, as I said earlier, are more vulnerable to dyspareunia. Women with recurrent vaginal infections, untreated STIs, or a history of pelvic inflammatory disease. Women with endometriosis or chronic pelvic pain disorders. Also, women with a history of pelvic surgery or obstetric trauma. And finally, chronic stress and anxiety also increases females' susceptibility because muscle tension amplifies pain perception. So for vaginismus, it's an involuntary spasm of the pelvic floor muscles surrounding the vaginal opening. The key word here is involuntary. The woman is not choosing to tighten her body, rather her body is reacting. Her muscles are contracting on their own without control. These muscles contract as a reflex response when thrusting is attempted. Now it happens automatically and not under conscious control, making intercourse uncomfortable, painful, or sometimes impossible. And this pain is from muscle guarding, not tissue damage. Some women describe it as feeling like hitting a wall, while others would say it feels like their body shuts down and closes. Vaginismus is now classified under the genitopelvic pain and penetration disorder in the DSM-5 manual, but clinically we still use the term because it accurately describes muscular response. The central mechanism of vaginismus is pelvic floor muscle stiffness, which is triggered by fear, pain or a learned protective response due to anxiety, previous painful sexual experiences or trauma, or episodes of dyspareunia that conditioned the body to anticipate discomfort in such situations. It has a primary and secondary types. For the primary vaginismus, it occurs when penetration has never been possible without pain. It is often associated with intense fear of pain, traumatic sexual experiences, strict sexual conditioning, or high anxiety traits. While secondary vaginismus develops after a previously pain-free period, okay, it can be triggered by an episode of dyspareunia, childbirth trauma, infection, menopause, or relationship distress. One painful experience leads to anticipatory tightening and the body learns to guard itself. Listen closely. Sexual trauma is strongly associated with this. Even if the mind has processed the whole experience, your autonomic nervous system may still respond defensively. Fear alone can trigger the spasm, and when the brain interprets intimacy as a threat, the sympathetic nervous system activates and the muscle contracts automatically. This reflexive tightening is a protective mechanism that's natural, but it can create a cycle of ongoing discomfort. Who is more susceptible to vaginismus? Women with high baseline anxiety, women with a history of sexual trauma, women raised in environments where sex was framed as shameful, dangerous, or sinful, women who have had traumatic or extremely painful first-time sexual encounters, women who have developed dyspareunia and began anticipating pain whenever intercourse is about to take place. Now, here is something crucial. Dyspareunia and vaginismus can overlap. This simply means that one can be mistaken for the other. A woman may initially have dyspareunia due to infection or dryness as a result of perimenopause or menopause. The pain creates fear, and the fear triggers muscle contraction. That contraction causes more pain, and a cycle of pain, fear, muscle tightening, and more pain forms persist if not addressed. A simple way to differentiate one from the other is dyspareunia's pain originates in the tissues or pelvic structures due to inflammation, infection, hormonal changes, and structural issues, while in vaginismus, pain originates from involuntary muscle contraction as a reflex neuromuscular response because the body is anticipating pain is about to occur. Sometimes both conditions exist together, okay? As a woman, you may experience tissue-related pain and develop secondary muscle guarding. Vaginismus is mainly characterized by the tightening at the vaginal entrance during intimacy or difficulty inserting a tampon or speculum when you go to your gynecologist, anticipatory muscle guarding before anything happens. But for dyspareunia, in superficial dyspareunia, there is a burning, stinging, rawness, or irritation at the vaginal opening. It's often accompanied by discharge or inflammation and improves once tissue heals or infection is treated and it resolves. But for deep dyspareunia, there is aching, pressure, or sharp pain deeper in the pelvis rather than just at the entrance, and may indicate internal pelvic pathology such as endometriosis or fibroids. Observation of these patterns helps you to differentiate the source of pain. Let's not forget that untreated dyspareunia can lead to secondary vaginismus because initial tissue pain from infection or inflammation conditions the body to anticipate discomfort. So that's when you have the reflexive pelvic floor contraction that develops automatically, especially when insertion is about to take place, and over time this protective guarding becomes habitual, layering muscle-based pain on top of tissue sensitivity. I know you want to know the treatments for it, and here we go. For dyspareunia, it begins with identifying the underlying cause. Infections must be treated properly. Hormonal deficiency may require vaginal estrogen therapy when appropriate, and endometriosis or structural pathology may require medical or surgical management. Scar-related pain may improve with pelvic floor physical therapy or scar mobilization techniques, and using high quality lubricants will aid reduction of friction related pains significantly. For vaginismus, understanding that the spasm is involuntary reduces self-blame. Pelvic floor physical therapy is one of the most effective treatments for vaginismus. Gradual desensitization with dilators, relaxation techniques, biofeedback, diaphragmatic breathing, and controlled muscle release are very effective. Cognitive behavioral therapy is also used to address fear conditioning and trauma issues as well. In selected refractory cases, injections into the pelvic floor may also be considered. Okay, now painful intercourse is not a reflection of your worth or character. Your body is giving you an information, it is not punishing you. Both dyspareunia and vaginismus are recognized treatable medical conditions. Understanding their differences is the first step towards relief and healing. Seeking help is a brave and powerful choice, and healing is very possible. You're not alone, and your body deserves care, respect, and understanding. This video ends here. Subscribe to my channel for videos like this. Like and share this video. Also leave a comment in the comment section below on what your experience has been, or if you know somebody that has experienced such. And I'll see you in the next video. Thanks for watching. Bye bye.